Welcome back, everyone. Thanks so much for joining. Today, we are getting the inside scoop with Jessica Joseph, fertility nurse consultant and injection expert. She is going to tell us from her experience as an IVF nurse what to ask your doctor when a cycle fails. Welcome, Jessica.
Thank you, Dr. Christina. I'm so happy to be here. Thank you for having me.
So before we dive into today's topic, let's have a little bit of background on you. Tell us about your background and why you founded the website Guided Fertility.
Absolutely. So I have about 10 years of fertility nursing experience. I absolutely love the field of fertility. On LinkedIn, I'm connected with a few different fertility nurse consultants, and I was very inspired with their background. I connected with a few, and I came up with the concept of Guided Fertility, my website. And it's been a learning process, but I absolutely love it. I love connecting with my clients. I love doing consultations. I'm available for my local community with injections, and it's such a treat and pleasure to actually do this type of work. So
Amazing. So tell us more about Guided Fertility.
sure. So Guided Fertility is a online virtual and educational service. It's for anyone who, wants a little bit more information on preconception planning, on, maybe they have, they're not quite ready for fertility treatment, but just wanted some more information. And then also for anyone who might be interested, I have a background in third-party reproduction. So anybody who's interested in maybe gestational surrogacy, egg donation, sperm donation. I've worked with intended parents, egg donors, egg banks. So I have a lot of experience in that realm as well. So
let's dive into today's topic, what to ask your doctor when a cycle fails. And
sure.
so I'll just start with that question. What do we ask them?
Well, it's multifaceted. So there's a few different types of fertility cycles, right? As we know, there's IVF, there's in vitro fertilization with the egg retrieval, then there's fresh and frozen embryo transfers, and then there's IUIs. So with IVF, so the way a cycle fails is one of two ways. There can either be a poor FERT result. So you have your egg retrieval. Let's just say you have 10 eggs retrieved. You get a call from the nurse or the doctor the next day, and none of them fertilized. And that can be devastating to a patient. The other poor result is when none of them make it to a blastocyst stage, meaning they can't be transferred. They never developed, or they're just too poor quality to transfer. So usually when this happens, depending on the clinic, sometimes the doctor makes the call. If the doctor's busy with procedures, the nurse makes the call. But one of two things happens. One is they encourage you to make a follow-up appointment with the doctor so they can kind of see, what you can do differently. The other thing that they tell you to do is wait 1 month. And this can be very, very, very hard for patients to swallow because a month for a fertility patient can seem like an eternity. So and there's a reason why we tell patients to wait a month, right? Because, the body kind of, when you go through gonadotropin cycles, gonadotropin medications, the injectable hormones, there's some degree of inflammation. So the body needs to recalibrate. That's one thing. The other thing is there can be leftover cysts from an IVF cycle. And it's not a problem. It usually resolves on their own, but it is a problem if you jump into an IVF cycle right away. So that's why you want to give yourself time off for at least a month, right? And during that time off, that's when you want to see, have a follow-up appointment with your fertility doctor. And some of the questions you can ask, and usually they bring this up, but you can also ask them, what can we do differently, right? You want to know what you can do. So one thing is, obviously, to state the obvious, you can change your medication protocol. You can increase dosages. You can maybe even change the actual medication. For instance, there's a medication called Omnitrope. I don't know if you're familiar with this medication, but it's basically, it's off-label usage. It's human growth hormone. So it tends to work with patients who are, who don't, maybe they stimulated, but maybe they had a certain amount of follicles that were in the right range, but some were on the smaller side. So it helps mature follicles, basically. And it can also serve as it can also help stimulate your ovaries as well. So that's one thing. The other thing I'm sure, Dr. Christina, you're well aware of is supplements, CoQ10, DHEA, DHA, and acetylcysteine. They all kind of help with egg quality, egg maturation, detoxifies hormones, things of that nature. So
yeah, I totally agree. I'm back to the Omnitrope.
Yes.
So is that something I've seen patients use it, like when there was a shortage of Menopur,
Mhm.
there were patients using it in place
Ooh,
of
yeah.
Menopur, and
Mhm.
the thinking was that the results maybe on certain cycles weren't as good. In
Mhm.
your experience using Omnitrope, is it usually in place of Menopur or in addition to Menopur and Follistim?
It's usually in addition. I've seen it used in addition. And also they use some other medications. You might be on a Lupron protocol. You might be taking dexamethasone, which is a steroid.
Mhm.
Yeah, so it's synergistic, basically.
Well, let's break those down because I think these are some of the questions that our listeners would want to ask. Like, what about adding this medication or that medication? It's something maybe the doctor wouldn't offer on their own. Um,
Right.
so, it's nice to have the information. So
Yeah,
the dexamethasone is a steroid.
right.
I'm guessing it's used for inflammation. What cases have you seen that been used in, and when
So
would you think that it would be helpful?
So Omnitrope, dexamethasone, and Lupron I've seen used in conjunction, and it's usually for patients, it's not first-line therapy. So I've seen it used in failed IVF cycles.
Mhm.
Patients don't respond, and it's very subjective. I mean, usually they base protocol on like AMH, FSH, age, antral follicle count. There's a whole slew of factors that our fertility doctor will take into consideration, right? So, usually this is not first line therapy, omnitrope and dexamethasone. It's usually like further down when either one cycle or a few cycles have failed, you introduce this because it is off label. It's not, commonly used for fertility.
Right. And so when I've seen dexamethasone used, I think there's one center in the city. I think they might use it in part of the retrieval cycle, but more I've seen it used, I think, in transfer cycles
And
to
transfer.
suppress,
So,
yeah, to
yes.
suppress the immune system. Yeah.
Yeah, so we used to use methylprednisolone, which is Medrol. So that was also used. And I think the theory behind that is, how if you were to get pregnant naturally, right, your body naturally immunosuppresses, so it doesn't reject the embryo. But then in a frozen embryo transfer cycle, you're manipulating everything, right, through hormones, through estrogen, through progesterone. So your body doesn't know to suppress, to immunosuppress. So that's where the role of steroids come into. It naturally suppresses you, so you don't have a miscarriage, basically.
Is it used in retrieval cycles too, or really just with the transfer?
I've seen it more so in transfer cycles. Yeah, but it's very clinic by clinic, center by center. So every fertility doctor kind of has their own way of approaching, you know, medication protocols. So
And then the Lupron, I've seen it used in priming, and I've seen it used in preparation for transfer. So when it's used leading up to a retrieval cycle or during a retrieval cycle, what is it being used for?
So Lupron is an agonist and it's an antagonist. So it can stimulate your ovaries and it can suppress your ovaries.
Mm.
So I've seen it used in a few different ways. You can use it in the beginning of a retrieval cycle to help suppress, right? We suppress first. And then what they do is they usually drop down the dosage to have it more, I know it sounds backwards, but to have more of a stimulating effect. So this way it stimulates your ovaries to have, to produce more follicles. Um,
And is that usually something that's used in cases of women with low ovarian reserve or like anybody?
it can be, yeah, it can be. Sometimes women who have higher FSHs, they might have harder times being suppressed. So then Lupron plays a role with that. Yeah,
Interesting.
yeah.
And in cases of, preparing for transfer with Lupron, like I've seen it in big dosages, like putting you into menopause to suppress endometriosis or
Yeah,
adenomyosis, which is
that's
a very unpleasant therapy.
yeah.
Um,
It
and
puts you,
usually,
yeah, go
yeah,
ahead.
and usually it's offered after the receptiva test has come back showing inflammation.
Right.
And so it's not my favorite. I'm more okay with it being used in a retrieval cycle. Uh, I have also seen it that it's more routinely used to prevent ovarian hyperstimulation in the retrieval.
Yes, correct. So, women who have hyperstimulation, they use Lupron trigger with a low dose HCG usually.
Mm.
So this way, this will help minimize symptoms, exasperation, inflammation, things of that nature. Yeah.
And so I have heard of like, various doctors that are like wizards with their medication protocols. And
Mhm.
and then there are other doctors that just kind of keep it the same a lot of the time.
Yeah.
And so, patients are asking about, why it didn't work. And from my observation,
Mhm.
it could be the cycle, like they didn't have enough antral follicle count, like enough follicles sitting there. It wasn't a good cycle. Or maybe they didn't respond well to the medication protocol. And
Um,
then if we weren't talking about IVF, if we were talking about, say, IUI
mhm.
and, the cycle failed, what
Mhm.
questions would you ask?
So it depends. So, and a lot of this is also based on limitations with coverage, right? So there's certain insurance plans where you have to do at least like 4 to 5 IUIs before you can progress to IVF, right? So unfortunately, some patients, they might be poor responders to IUI cycles, but they have to wait, you
Mhm.
know? Um, but with IUI, like what you can do is once you, I guess, hit your whatever 2 or 3 cycles of IUI and it's not working, usually there's something called step therapy protocol. So you go on to the next step, which is usually IVF, right? And so you can just say, usually a doctor would recommend if it's just your first IUI cycle that's failed, try another round and see, they can adjust the Clomid dose, the letrozole dose, whatever it is, and see if that might help. But yeah, it's step therapy. So start with the most conservative route, right, which is IUI, and then advance to IVF.
Have you seen that a cycle off can be very helpful in improving the results? Because a lot of people go back to back these days because they used to tell you that you had to wait a cycle. And now a lot of centers are like, let's keep going. And you can
Right.
even do luteal phase stimulation, like you can do 2 retrievals in a cycle. So,
Yeah.
is the thinking generally in your field that, waiting a cycle out really helps, or it's more just to like, lessen the burden on your body?
Well, I think it depends on the type of cycle. So IUI, there's less chance. There is still a chance of hyperstimulation, but not as much. With Clomid, I mean, rarely doctors prescribe gonadotropins with IUI, but you don't really see it that much because of the case, a high risk for
Mhm.
multiple pregnancies. So with IUI, I think it's okay, as long as the patient's feeling okay. With IVF, I think it's case by case. Like if you had a cycle where you hyperstimmed or you had an adverse reaction, sometimes it's good to take a month off. But if the doctor feels like there's no contraindication for you starting a cycle right away, if you don't, you come in at baseline, your blood work, your sonogram, everything's normal, there's no functional cysts, you're feeling okay mentally, then yeah, then sometimes they might start you right away. But I think it's better just to wait, just it's very taxing on the body, it's emotionally, psychologically, physically, it's a lot for our patients. So
Yeah, I think it's just like you said at the beginning, though, that they're like just so ready to get the show on the road that waiting another month it's just unbearable. And then there are people, like at least in New York, there are people who come here just for IVF and they're staying here, they're paying for their accommodation, they're paying for their cycle, and they're like, no way am I taking a month off. Like I'm here, I'm going to do, a few cycles in a row and try to get this done. What are some of the challenges for women going through reproductive assisted reproductive technology, like for the women, for the centers, like are the doctors really busy, they can't give all the attention they need, that's why you started your thing. Like what are some of the challenges that you observe or that we need to address to make fertility care better?
you know what I really would love to see more, and the last center I worked for did have this, but I like the integrative approach. I think a lot of our patients want to feel empowered, and that's why I love your center. I go on your website, I listen to your blogs now, and I love all the really solid advice that you give. So you're doing really great work.
Oh, thank you so much. I appreciate it. So, Jessica, where can our listeners find you?
Well, I have my website. It's guidedfertilityrn.com. So, yeah, so the best way to find me right now is on my website.
Okay, great. Thanks so much for being here.
Awesome, Dr. Christina. Thank you for having me.